Welcome to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. Welcome, everybody. It's Josh and Adam in your favorite medical evidence, all things podcast, Dr. Journal Club podcast. Today, what are we talking about today? We had a few topics we were shooting back and forth in the green room.
Mm-hmm.
What do you, what's on your bucket list? What do you want to cover today?
One thing that I wanted to there's a couple of things I want to talk about today. One was another network meta-analysis on some diabetes medications, because the New York Times had, was it the New York Times or was it?
I looked it up. It was a CNN.
CNN. Okay,
Yeah.
So CNN had a pretty verbose, superfluous article on GLP-1 agonist
scaremongering, I would
say. And just really kind of it goes into the topic of like medical journalism and as a clinician, are we using
quotes around the journalism or no? We're not quite.
No, let's not get into that. But as a clinician, medical journalism is something I've always kind of struggled with, because I do understand the importance of having access to knowledge to the general public. But at the same time, you have the danger of access to the general public without the medical training or the context of even evidence-based or evidence-informed practice training. And so without that, and with a lot of sensationalizing things, a lot of things in medicine there's a lot of gray and there's a lot of nuance. And if you can't have that conversation, it's not sexy to sell. So no one's going to want to read on CNN a nuanced discussion of GLP-1 agonist therapy risks and benefits. They're going to want to see something that grabs headlines and clicks and whatnot. And so that's kind of what the article led to. And I know that patients may bring it up. I know practitioners who have a bias either against medications or for medications, or for specific therapy or against a specific therapy, may kind of unfortunately grab onto those headlines to support their biases. And I think that we should talk about that eventually, with support from a very recent, very well done network meta-analysis in the British Medical Journal that was guided by our favorite Gordon Guyatt.
Yeah, it's a good case study, I think, in really good research versus high-level journalism trying to do their job. Let's try to get into those nuances. And one of the things that you and I talked about early on was one of our values is steel manning, right? Like, we don't want to take pot shots. And I apologize for the journalism comment. That was uncalled for. But we want to try to steel man people and say, okay, taking them at their best possible light, what do we think's going on here? And why do we think we agree or disagree? So, so I want to talk about that. But also, we would be amiss if we didn't mention the threshold that we crossed recently.
Do tell.
Well, there is a minimal important difference for podcasting of 1,000 downloads, above which you are awesome socks, and beneath which you're not quite awesome socks yet. Yeah. We passed at the 6-month mark, just about the 1,000 download mark on Buzzsprout, which is our hosting site. We have more downloads than that across like YouTube and different sites as well. But it felt like a big milestone for me. I don't know about you. And I wanted to kind of take an opportunity to reflect on that a bit. And, we're half a year in of this 1-year experiment that we said we would do. Like, what are our thoughts, so far in the future? What does success look like? What does acceptable response look like? What does the minimal important difference look like? Anyway, so we should talk about that too, but maybe we cover both topics today.
Yeah, I mean, I think, well, one, thank you to all the listeners for listening to us just kind of
Yeah, props
ramble.
everyone.
Honestly, this just started out as me and Josh just kind of nerding out via text and email and being like, hey, what if we had a podcast? And we were both like, oh my God, like, yes, we've been wanting to do this. It gives us an excuse to kind of like just hang out and chit chat for an hour every morning about just random topics. And so then to have other people listen to us just ramble on about whatever, and seem to have some interest. This has been really exciting to see, and yeah, it's been fun. And so thank you for everyone who listens. I do wish we had some more engagement from the community. We have had some people reach out and ask questions and stuff like that, but if more people, like if you guys just are like, hey, I have a cool paper, can you guys break this down, I'm confused, or can you talk about this, I'm really interested in this, I want to hear your take, or just honestly anything from you guys would be awesome to talk about. It keeps us engaged, it keeps us thinking, keeps us kind of looking in things that are outside of our interests. So more community engagement would be awesome, especially amongst the social media platform. Like we want to hear from you guys, but all things, good, bad, anything. Give us 5 stars on Apple Podcasts, rate us on Spotify, et cetera, because that stuff matters. It drives the algorithms. And so, your guys' word of voice, your sort of spreading the podcast, will only help us to grow the podcast. And, we're not getting paid to do this. So this is honestly just, a pure love and enjoyment of just kind of talking about medicine and evidence-based medicine and sort of all these topics that are involved with it. So make sure you rate us on things like iTunes, leave us reviews, tell all your friends about us, et cetera, et cetera.
Yeah, that's true. And yeah, I would say on reflection, like I'm really proud of us. Like we did from nothing, for knowing nothing about podcasts, right? Like we put this together, we got some decent equipment, we're making a decent product. We've had some amazing conversations with people, and we've had some good engagement, like people reaching out, emailing us questions, calling us, leaving us messages, doing voicemail. We did some of that on the pod as well. Sending us articles to review, like we did with SSL last week. And I love it, but I agree with you. I think as far as like moving forward, what I'd like to see is more engagement with the community, right? So we have to think about how we can do that better,
Mm-hmm.
and have these conversations, because I think they're important, and they also just lead to great conversations on air, right? Because when we get those listener questions or those listener articles, it's fun, it's relevant, and it's I feel like we get a pulse on the clinical community too, like what are people thinking about as well. So that's something that let's see if we can't do a little bit better on the second 6 months, and then all our listeners, you should weigh in, let us know how you think we did. Awesome. Okay, cool. So that's awesomeness. Let's talk about medical journalism. So a little bit of context. So we've done, you've done a bunch of Dr. Journal Club videos and reviews on recent papers on GLP-1 agonists. And we've been, relatively excited, I think, as the medical community is, about these results. And, maybe a few months later, I'd say we were early. It just took over the news cycle. Like it's just everywhere. You hear about, Ozempic, Wegovy, semaglutide, like it's just all over the news. And now there's a new class of meds coming out. And with that press, I think now there's a little bit of a backlash. And so what we're referencing is there was a CNN piece, I guess a couple days ago, that was going around, and maybe you can share some background about that. And I'll tell you, my finger on the pulse of the community is my mom.
Mm-hmm.
So when she's a doctor, but not a medical doctor, and so when she's a very smart woman, she's very interested in sort of everything, but also like sort of new to medicine. And so when she sends me articles that she's interested or curious about, I know that it's relevant to the larger thoughtful community. And so when she saw this, it didn't even go to my email, it just went straight to my text with like exclamation points, like, this is not a wonder drug, and so I thought, what, let's dive into it a little bit more. You were saying as well that had picked up some press around you too, and some interest, and I'd like to use it as a exemplar of medical journalism compared to medicine, compared to evidence, and what we need to do about that.
Yeah, and I think it's also important because a lot of, at least my encounters with patients, and I think certainly a lot of the clinicians out there listening would probably agree that so much of our appointments are just based on developing a relationship with our patients, wanting to get to know them, get to have you guys trust in our medical decision making, and all of that kind of stuff. And so, when you have these discrepancies of what your physician is telling you, and then what you're seeing in the media, or what your family members are telling you, or what may even be like politically driven, then we start to have this divide within our patient doctor relationship, and all that trust that was built within that relationship in the medical community at large. And so we don't want any sort of falters in that trust that we have with our patients. And so when articles like this come out, I think it is important to kind of jump ahead and just kind of have a healthy and safe discussion around what's going on.
Mm-hmm.
And so the thing is, for background context, when it comes to the management of diabetes, we care a lot about the management of diabetes, not just because like, oh, your sugars are high. It's not necessarily a sugar issue. It is a sugar issue, a glucose regulation issue, but it's the consequences of chronic high exposures to elevated sugars that leads to medical complications later on down the line. So things like kidney disease, loss of vision, loss of limb because of infections that we don't realize because we're getting ulcers that then infect the bone. Neurological disorders that affect not only sort of like this numbness, tingling that a lot of people with diabetes may report, either numbness or tingling that they report, or just absolute lack of feeling. And so then if they step on a nail, or they get a burn, they actually don't feel anything, which then leads to complications because they don't know they have it. Or it can lead to neurological issues elsewhere in the body, such as in the stomach, a concept known as gastroparesis, where the nerves within the GI tract are actually so damaged that these people are having difficulty, having a bowel movement, or end up with significant nausea and vomiting because food is not moving through the GI tract; it's just kind of sitting there. And so, you have a lot of these complications from diabetes. Unfortunately, with all the treatments that we have, a lot of the older medications have not actually proven benefit for the prevention of a lot of the things that we care about that diabetes is so largely responsible for, that being heart attacks, strokes, kidney disease. And now only recently, with the intervention of drug classes such as SGLT2 inhibitors and the GLP-1 agonists, GLP-1 agonists being things like semaglutide, which is brand name Ozempic and Wegovy. We get no financial compensation or any sort of conflict of interest with that. However, those two classes of medications really are the only two that have consistently proven to show benefit in the prevention of heart attack, stroke, heart failure, kidney disease, et cetera, et cetera.
So outcomes we really care about, not the surrogate of blood sugar regulation.
And that's not to say that, our A1C levels don't matter. It's just to say that with other medications, when we have gotten down to our A1C targets, we're still not necessarily seeing prevention of heart attack, stroke, et cetera, et cetera. Because, you don't want someone just chilling at an A1C of 14%. There's a big difference of being at 14% versus 8%. So the targets do matter, but it does also appear that the agent with which you are using, or agents that you are using to achieve those targets, also matter a lot.
Which
And
is
so
quite
now,
interesting. So it's not a direct, it may not be a direct, you bring your sugar levels down and therefore the outcomes we care about comes down always. It may not always be that direct.
Right. And now that we finally have two classes where we're actually seeing benefit in the prevention of cardiovascular disease, especially, where we're really excited as physicians to be able to afford these things and obtain these hard outcomes, or these prevention of hard outcomes like a stroke or a heart attack.
Mm-hmm.
And then also with GLP-1 agonists in particular, we're also seeing significant weight loss benefit from it. And with the ongoing obesity epidemic, this has been huge. It's been a game changer when it comes to management of obesity. And now that there's more formulary options on insurance, although the medication is rather expensive, I am noticing as a clinician a lot easier access for patients in getting coverage for these medications and not having to pay thousands of dollars a month for it. Some people are getting them for quote unquote free, meaning they don't have a copay. Some people are having like significant discounts on these medications, and so the availability of the medication has significantly increased. And so now we're seeing more prescribing patterns leaning towards these medications. You're probably seeing commercials all the time, especially for Ozempic and Wegovy, because they still have patent on their medication, so they kind of dictate the market, and it's not generic just yet. So that being said, the pharmaceutical companies are making a big profit off of this. However, as clinicians, these are great medications to prescribe for the effects that we're trying to get.
Right.
However,
Mm-hmm.
with medications, although there are benefits, there are also risks that we need to discuss with all of our patients. When it comes specifically to the GLP-1 agonists, unfortunately, gastrointestinal side effects are rather common with their use, and those side effects range from self-limiting to being pretty intense. And I've had to take some patients off of those medications, or have had to significantly reduce the dose because patients just do not tolerate the side effects, unfortunately.
And you presented on a paper that quantified that. I think it was 2.5 times more likely to stop the intervention because of side effects with GLP-1s versus like placebo or lifestyle, right? So it's not a small it's not a small effect. It's 2.5 times to 3 times more likely. It's very common to get these side effects, and very often people will stop. It's so bad.
Mm-hmm. Yeah, this was the Gordon Guyot paper that was published in the British Medical Journal, and it was a network meta-analysis looking basically at all the diabetes medications that from basically existence up until today, for not only the benefits but also the risks associated with use. For those hard outcomes that we were talking about, for heart attack, stroke, et cetera, in addition to the weight loss benefits. And when we look at the specific, drug adverse effects, when it comes to our GLP-1 agonists, the severe gastrointestinal events, on average, there is an odds ratio of 1.97. So let's round up to 2, like Josh was saying. And that ranged from a 1.4 to a 2.8. So let's just keep numbers pretty easy to work with. So the odds of some sort of gastrointestinal event is twice as likely with their use, and that ranges from about 1.5 to 3 times the odds of experiencing some sort of severe gastrointestinal event. But the trade-off is prevention of not only cardiovascular death, non-fatal heart attacks, non-fatal strokes, but also all-cause mortality, and improvements in health-related quality of life. And then when we actually quantify that as to like, okay, well, what does that mean? So if I were to treat 1,000 people with some sort of a GLP-1 agonist, I would be able to prevent 13 fewer deaths from cardiovascular disease, 10 fewer heart attacks, 16 fewer strokes, 17 fewer deaths from all-cause mortality, with the exchange of 40 more people having severe gastrointestinal events, with that ranging from 16 to 72. So you would have to kind of look into the definition of what was considered severe gastrointestinal event. Is it the development of constipation that was so severe that patients just wanted to stop the medication out of discomfort? Or are they now having, let's say, rectal bleeding, right? So we kind of have to define or see what we define as a severe gastrointestinal event. My assumption is that from the paper, and I have to go back and look, is that severe GI effect was just a side effect that resulted in discontinuation of the medication. So maybe
Yeah.
they just had some nausea and they're like, you know what, I don't think it's worth the nausea. And for some people, they may have developed, a severe like cyclic vomiting syndrome type of thing. And that was one thing that the journal article in the lay media was talking about was, hey, we have, we had, I think, what, one or two cases
I
of
think it
people
was
just having like
two case studies of people that were claiming it caused long-standing effects even
even
after
after
stopping.
discontinuation. Yeah. So they were on it, they stopped it for about a year and were still having side effects.
I think one person had gastroparesis, one person, cyclic vomiting.
Yeah, but the confounder there, at least with the gastroparesis case, and that they did mention was that diabetes does increase the risk of gastroparesis. So it was sort of a chicken or the egg phenomenon. Would this
Mm-hmm.
person have already developed gastroparesis? Were they already having gastroparesis, and the GLP-1 agonist just sort of exacerbated things? Was there a true hormonal effect that has persisted for a year since discontinuation? In my opinion, without really knowing much, I would be a bit skeptical of that. But I don't, we need, I guess, more long term data from GLP-1 agonists to see if that's true. But
Yeah.
we have that's just two cases in the lay media versus trials of hundreds of thousands of people, where for the most part we're seeing benefit.
Yeah, so I think thanks for that summary. I think that's a really good summary of where we are. And what I wanted to talk to you about that was I think there are a couple like meta concepts that are coming out. So one is the causation issue, right? We have these two case studies. This medication class has now been prescribed probably for millions of people. So, how confident can we be about causation? Right? Is it coincidental? Is it indeed related? If it is, what's the rate of these sort of severe, lasting concerns? And then the other thing I think is a trade off question, right? Let's say, for sake of argument, let's steelman it. Let's say that these are real, right? That it is causal, and that it's present in some small percentage of people. I don't know what it is, and you're right. The paper that we're talking about didn't delineate. They basically considered severe adverse events something that led to discontinuation. They didn't really lead to separated out by long standing and stuff like that, which I think would be important and interesting to get a sense of that rate. But also randomized trials, which is what this was on, are not really good at identifying rare, long-standing events, right? So that's what surveillance studies are essentially later, once it's out to millions of people. And then back to the trade-off question, I think a lot of it comes down to baseline risks. So if your population, and I think the study we're talking about is a diabetic population, right?
Mhm.
Okay. So if your population is diabetic, I think the trade off is a no brainer, right? Because you're literally preventing heart attacks, strokes, and death. And, you have some, very rare side effects, right?
Well, I
Um,
think I
yeah.
think I think in the terms of like a pure evidence standpoint, like yes, the it's a no brainer. However, we still need to approach each decision that we make with our patients on a one-on-one basis and
Hmm.
value our patients' choices, right? And so if we explain to patients and say, hey, here's the data, here's what the benefits are, here are the potential side effects. What are your concerns? Do you want to start this? Do you feel like you feel prepared for this medication? Do you want to hold off? Do you not want to do it? And if they say yes, then you respect it. If they say no, then you also respect it, as long as you're both having an honest and understanding conversation.
Yeah, I think that's well said. And actually, one of the things that really stuck with me from the most recent pie was something that Gordon Guyatt spoke at the most recent pie, and one of the things he said that really stuck with me was when we're talking about informed consent, like and these conversations, shared decision making with patients, when things medically are like very very straightforward, like you have a high risk of a heart attack and gives you a high chance of survival, it's usually a pretty strong push by the clinician, right? There usually isn't much nuance there, although there might be, and your points are well taken. The area where he was arguing shared decision making really lives is in that gray zone, in that gray zone where it isn't so one sided, and patient preferences will make a huge difference on the right choice for the patient. and individual patient characteristics will make a big choice. So back real quickly to the baseline risk. So we've got one bucket of population, which is diabetics, which is a high risk population. Another bucket of obesity, which, yeah, like it's not diabetes, but it's a risk factor in and of itself. Many people consider it a chronic disease in and of itself. It leads to all sorts of horrible outcomes. You can make a strong argument for that as well. Maybe not as strong as diabetes, but pretty strong. And then there's a third bucket, and I think this is where, if we steelman the CNN paper, or not paper, CNN article, this is, I think, their point, which is it's now come into mainstream culture where people are taking it to lose 5 pounds, right?
Mhm.
Where they're not at risk, they're not obese, maybe they're overweight, maybe they're normal weight, but they're want to lose 5, 6, 7 pounds, etc. And they're getting put on these meds. And at that situation, I really think the trade-off calculation shifts, because the benefit as far as preventing this stuff obviously is minuscule because they're not really at risk for these terrible things. But the side effect profile is very high. And even if there's rare, long-standing events that are of serious concern, like gastroparesis or cyclic vomiting syndrome, if millions of people are taking it, those are now real numbers. So
Right.
I'd like to get your thoughts on that. I think, again, thoughts on causation and what we can do with a few case studies in a CNN article, but then also, if it is real, how does that trade-off play into our decision making?
No, I think that's a good point from you. And I think, one thing that we have to take into consideration is like it's only two case studies or case reports. However, we can't poo-poo those reports either. We can't throw the baby out with the bathwater and be like, oh, great, now no one should be on a GLP-1 agonist. But at the same time, we also can't just be completely skeptical and say, oh, it's only two cases, ignore it. Like, that's just a bunch of media hype, fake news, whatever you want to say. Ignore it. We kind of have to say, okay, maybe there's something here. We need to investigate it. We have to be aware of the consequences of what can happen when we're prescribing these kind of things, and just kind of be aware of it. um, but I think it's also, to your point of like, yes, we also can't sensationalize the therapy that's available, where you're having celebrities want to use a medication that's really important for people with an actual medical condition, just so this way they can look better on a camera. Because then, one, you're also decreasing the supply that's available for those patients who need it. And we actually did run into that, where there was a huge shortage of one GLP-1 agonist known as Trulicity. And that was frustrating because people were using it for weight loss when they didn't have a medical need for the weight loss. And then, here are my patients with diabetes actually needing the medication, not being able to get it. Um, and then I think it also highlights this idea of health at every size, which is essentially like, don't blame obesity on everything. Just
Mm.
because the patient in front of you is of a larger body habitus, it may not necessarily be explaining what's going on. Um, Now, granted, it kind of depends on what the chief complaint that they're coming in for is, but um, don't just put people on necessarily on a GLP-1 agonist just because they want to lose weight if there's perhaps no medical reasoning for it, and kind of look for ulterior motives. Like, are you losing weight just because you want to feel better? Are you wanting to lose weight because maybe there's some sort of orthorexia or anorexia that you're not disclosing? So there's these other things that we also have to think about as clinicians. And if someone wants to, simply lose weight, perhaps kind of use that time to have a conversation with them as to why they want to lose weight, and kind of look for, sort of other, discussing other alternatives rather than just quickly prescribing something.
Hmm.
Um, or again, like, not just blaming the obesity on whatever they're coming in for.
So I agree. And one of our listeners, Dr. Mark Davis, reached out to me recently. It was like, "You guys are a pretty good foil. You don't always have the same opinion," and I think that's probably true. So just to foil that a little bit, on the flip side, right? On the flip side, I think there's also a tendency that I've seen for clinicians to blame the patient if they're not losing weight. So let's say a patient comes in and wanting to lose weight, and it's like, I need help here. I've tried every diet. I've spent a fortune. I've spent so
Hmm.
much time and energy. I'm not losing the weight. Can I try a medication? And I think what at least a lot of my patients are reporting, and what I'm seeing is this sort of like, well, you must really not be trying, or, really it's just, you just got to eat less, eat more salads and move more, right? And I think that can be very dismissive to patients. And I think there's also an argument to be made about intention to treat here. Like,
Mhm.
yes, it is true. If you only eat 800 calories a day or whatever it is over a period of time, you will lose weight. It is true that all these things have been shown to make you eat less and lose weight. However, in real life, intention to treat is, this stuff is very difficult to do and to sustain. And
Mhm.
I think this idea that, oh, well, I'm not going to prescribe this medication for you because you're just not trying hard enough. You're obviously just lazy, and this would be too easy for you. Like, I just feel like whether that's conscious or unconscious, I think that message is also coming through.
Yeah, and I think, I mean, just in medicine in general, we have to stop. We can't blame our patients just because of, just stop blaming the patients. Really, is kind of
Let's start with that.
is kind of
That's a good
the
place to
short
start.
end of this. Kind of understand. Okay, why are they struggling? What is going on? How can we help? What are the barriers to the results that they are or are not achieving? So that's one thing. And then kind of on that discussion too is you'll see some clinicians not want to prescribe because they say, oh, well, now you become dependent on this medication because the data shows that once you stop a GLP-1 agonist, you just get a bunch of weight regain, which,
Mm-hmm.
yes, the data does show. However, to my understanding, although there is weight regain, it's not necessarily to the point of what your initial starting weight was or going above that starting weight. It's still kind of lower than what that weight was when you initially started the medication. And what's also likely going on is if you're starting the medication without the sustained lifestyle and dietary habits to assist with that weight loss, if you don't have that lifestyle foundation in place, then perhaps that weight regain happens a lot faster. Meaning like if you're someone who's locked in with their diet, their lifestyle, they're enjoying what they're doing, they're able to maintain those changes. When they stop the medication, in theory, they should be able to maintain that weight loss to a certain extent, as opposed to just like a complete, uh, you know, rebound. However,
Is that what
that's
the data shows? One of the
I'm
papers
not
that I
going to
think
say
is on
that's
our,
what the data shows. That's something that I
yeah,
have to look into more. I don't want to give any sort
because
of false information out there.
there is evidence of rebound weight gain on stopping. That's a paper. I think it's on our docket to do on Doctor Journal Club, but we haven't looked at yet, right?
Yeah,
Yeah.
yeah. It's just and this is just like kind of it goes down to like the neuroscience of weight loss. It's very difficult to maintain weight loss, and Stefan Guillenet has done a really good job at this. He was a PhD researcher. He might still be at the University of Washington, who does a lot of obesity research, and he wrote the book The Hungry Brain. And basically, when it comes to weight loss, we have sort of a set thermostat, if you will, in our brain as to what our weight should be. And part of the issue when it comes to obesity management is if we go above that threshold and we're gaining a lot of weight, we kind of set a new threshold and then we kind of become stuck there.
And
And
you
then
can't
so
reset it down after like losing a bunch of weight
it's
type of
it's
thing.
difficult to maintain that reset. So let's say you're at 250 and you overconsume calories for a prolonged period of time, and now you're at 300. You've been at 300 for a while, and you want to lose weight, and so you do a good job with diet lifestyle. You go down to, let's say, 200. You've set that thermostat low down to 200, but its baseline is 300. And so from a survival mechanism, the body wants to work really hard to get it back to that 300 that it's set at. And there's a lot of things that are driving that. And so you're kind of like battling against your own physiology to maintain your new set point. And I think that I'm not sure if the data is already kind of like confirmed that it's that you can't reset the new set point, or if it's actually attainable. It's just a matter of like time at that new level. I have to go back and look at the data, but basically, now that you're at 200, you kind of have to hang out there for a while before that's your new set point and
That makes
whatnot.
sense. Yeah, so that would make sense too. That the for rebound, and one of the things. So we did a paper a couple years ago on keto diets, on low carbs and very low carb diets, and we saw pretty strong evidence of impact on diabetes, but also on weight loss. But also, it's the same story that we saw. We were so excited about these results at the 6-month endpoint, but when you look at 1 year and 2 year endpoints, like essentially everybody comes just back to normal with that
Mhm.
particular diet. And actually, it was a comparison against other diets. So with all the diets, essentially, like my understanding of the literature, which is pretty nuanced at this point around diets, is essentially, yeah, most of them work. Many of them work very well. Some of them work faster than others and stronger than others. Like, for example, at least in our research with low carb diets and very low carb diets. But at the 2 year mark, they're essentially all the same, which is essentially you've regained everything.
But does
It's
that come down
yeah.
to an adherence standpoint of like, okay, at 2 years, people are having a hard time maintaining that, and so
So
perhaps it
let me
doesn't.
ask you a question. So does it even matter on a population level, right? Because maybe it's adherence, right? Maybe that's true, but maybe it's not. Maybe it's there's some physiologic argument and that's maybe interesting, but in real life, it almost doesn't matter. If you're giving thousands and thousands of people a recommendation and no one can follow it at 2 years,
Mhm.
then that's all the information I feel like we need. And this is the thing that pisses me off about these doctor conversations I think with patients is like, well, we know that all, XYZ works. Well, we know it works for 6 months. We also know that it's very, very difficult to follow long term. So,
Yeah.
anyway, that's one thing. Another question I had for you, I saw on one of the guys you got me into on Instagram. I forget his name now, Dr. N something.
Nadolski?
Um, yeah. I really like him because he's a tri guy. He's like around my age anyway. He's got a young family and he's doing triathlons. And he, his argument is obesity is a chronic disease, and if you stopped hypertensive medication, of course you would expect your high blood pressure to jump back up again, right? And so he's not so surprised that if you stop your GLP-1s that your weight's going to come back up again. He's like, well, why would that be any different? And I think it's an interesting question, and we and perhaps correctly, we tend to think about diet and lifestyle conditions differently and weight differently, even though diabetes also is a diet and lifestyle condition. So I don't know. I feel torn in my soul because I'm a naturopathic doctor, right? And so the fact that I'm relatively excited about a medication over diet is hurts at the deepest level, but also there's the evidence-based side of me, and it's like, for crying out loud, look at this data. And then, like, I don't know, I'm having a hard time making sense of all this. And the anyway, yeah, what do you make of all that? I'm just rambling at this point.
Well, I mean, I think to get into like the philosophy of it, I don't think it really matters what kind of provider type you are. I think if you're going to take a holistic approach to, to medicine, you're taking into account all the available options and just having a discussion with patients. You shouldn't really have to. Shouldn't really matter whether you're doing a medication or a lifestyle intervention. Like you shouldn't be biased one way or the other. It should really ultimately be what's the safest and most beneficial to the patient, taking into account their preferences and yes, what the evidence supports. So just because you're a naturopath who prescribes, who cares? Um, Likewise, if you're a naturopath who refuses to prescribe, there could be harm in doing that because the amazing thing about modern medicine is that we can achieve improved health status with the use of medications, and modern medicine is awesome. So I think you have to be okay doing both. So that's kind of just my tirade there. Um, but yeah, I mean, I think we are kind of rambling, but I think it's important to understand that um, there is a nuanced conversation to have. I think that just in medical reporting in the lay media, things are sensationalized a lot, and it's just about when that happens, having a safe, healthy conversation with the patient who brings up those concerns and not dismissing them, and understanding both sides of the argument, and just having that honest conversation with them, because as clinicians we should be prepared to have those conversations. And if you're not prepared to have those conversations, referring them to a specialist who can have that nuanced conversation and kind of talk with the patient about what the risks and benefits are of the medication as a whole from the data that we have and the person that's sitting in front of us. And so that's kind of that's just my take on it.
Yeah, I think that's fair, and I think that's true. And I'm also recalling. Did you ever get have a class with Eric Yarnell
No.
in your training? So I just respect him so much. And I remember when I was a student, and this is, we're bright-eyed naturopathic students, right? So we're, everything conventional is, suspect at least, right? And then our teachers tried to convince us that that's not true. It's like, no, it's much more nuanced than that. But that's what you go in with, right? You have this sort of ethos going into a program like that. And I remember, we were talking about weight loss, I think, and heart disease prevention. And I remember in class, he was like, everyone, students were talking about their different diets that they would do, and I think it was a case study. And he was like, honestly, you know what the data says, and this was 10 years ago: bariatric surgery. And it was like, it just kind of blew everyone away, and everyone was
Mhm.
so appalled. And I remember this collective gasp that
Mhm.
came up, right? And it was like, well, that's such I don't know, a heroic fix, heroic in a bad way, like sort of
Mhm.
historical medicine, heroic fix to, something that the patient can just fix with their diet if they learn enough about diet and everything. And what he was trying to suggest was, well, I hear you. And like, when you look at the research, like, this is the only thing that we know that prevents heart attacks, strokes, and death. And that was, of course, before all these new classes came out. And I just remember what an influence that had on me, where you had a naturopathic doctor that, we respected so much, come up and say, you know it's not always about that. You have to sometimes look at the evidence here and see what's going to help the patient the best. And that really, really helped me, I think. And I wonder if this is a shift in that way. But anyway, there's a few
Well,
topics. Yeah, go ahead.
just to build off on that, I think that a lot of people, and I see it sometimes with patients too, who ultimately view bariatric surgery as like almost like a failure on their end,
That's
and it's
right. Right.
not.
Yeah.
It's not a failure. It's an option that we have, and the data supports its use and sustained benefits over a long period of time, and we see reversal of a number of health conditions. We see non-alcoholic fatty liver disease essentially resolve overnight, diabetes resolve overnight. A lot of these chronic conditions just rapidly improve. And the thing is, when you refer out to a bariatric surgeon, they're not just going to see them and say, okay, here's the procedure. We're going to cut into you tomorrow. Like, see ya. I love referring to bariatric clinics because they set the patient up with a nutritionist. They get a lot of labs. They do work with them from a holistic standpoint, making sure that not only going into the surgery they've achieved a specific weight loss this way that the surgery is successful, but also they're able to maintain the benefits from the surgery and maintain that weight loss. And sort of like, here's how to to eat and live post surgery. And they work closely with their nutritionists and whatnot, and they have specific thresholds that they need to meet. So it's not like you just go in and, you know, you get a surgery and they push them in and out like a factory. There's a lot of there's a lot of nuance when it comes to that. And, I love working with the bariatric centers that I refer people to.
Yeah, I think that's a good point. And the other thing I'd say is, I'm also open to something coming out tomorrow saying that bariatric surgery is evil, and really this is the diet to do, and these are the greens to eat, and this is the superfood that will save us all. And then I will change my opinion, right? And I think one of the things that came up at the PI conference when we were, talking about the bigger picture of what is evidence-based medicine, because PI is for chiropractors technically, although not much that we actually talked about was for chiropractors, but they have a similar concern. People are coming in very holistic, and the question was, what is an evidence-based provider? And at the end of the day, it was like someone who's willing to change their mind, and
Hmm.
this is what when the data changes, right? And this is what the one of the keynote speakers, it wasn't Dr. Guyot, it was a chiropractor, so it's even stronger coming from them. I might have already told you this. Basically, went up on stage in front of everybody and was like, what would happen if tomorrow a really good study came out that showed that chiropractic adjustments were no better than placebo, right? Like, what would you do? I hope that we would shift what we do. And I think that's what an evidence-based provider is.
Hmm.
And one of the things we have to question is when we're so married to our position that we get this knee-jerk tribal response when new data comes out. I think we really need to question that. Now, that might be correct. Our response might be correct, but it's almost like a red flag warning, I think, about like, oh man, maybe my thoughts are a little bit too ingrained here. And like, for example, I'm a SIBO doc, and I've had a small intestinal bacterial overgrowth, and I've been using particular device. I don't have any financial relationship with the company, and I've done a bunch of continuing education on the evidence behind it. I had a doctor reach out to me yesterday and was like, "Yeah, I'm looking at this and I'm highly suspect about its utility and but like some pretty good arguments." And I was like, "Oh, this is great. Like, let's talk about it, right?" And I'm very open to the fact that I could be wrong. And whenever I give these talks, it's like, this is my understanding right now, based on the evidence that I have in front of me right now, and this could change tomorrow, right, with a new interpretation or new data set, et cetera. And so I think the best we could do is say where we are right now, and then to your point, with the patient in front of us, this particular patient in front of us, what is the best application of this evidence in a way that makes sense for the patient, right? And that is the evidence-based medicine.
Yeah, no, I would agree. And I would say, I think a lot of times when it comes to clinical practice, we kind of become so accustomed to our own either prescribing habits or how we sort of like we approach a situation, just because we see a lot of medicine as a repetition. And so we kind of, whether subconsciously or not, we kind of create our own algorithms as to how we treat things. And then when those become challenged, we kind of take them personally. And so I think if you do become challenged as a clinician, sort of like lean into it and kind of explore that and say, okay, what am I missing? Am I wrong here? Why am I being challenged? And kind of look into it. Because then when you start to question yourself, then you start to look into the evidence and you can say, okay, well, maybe I do need to change something. Maybe I'll stop prescribing this and I'll go with this. Oh, there's this new thing coming out. Let's look into it. Okay. It looks promising, but it's still new. We need to kind of confirm it with more. We need long-term data, et cetera, et cetera. So yeah, if we have a paper, that comes out and shows that, hey, GLP-1 agonists actually are causing our toes to explode, I'll have to take that into consideration. But for right now, we don't have that data.
Right. I think that's true. And I have to tell you, to be honest, and this is why it was a red flag for me, is when the doctor reached out to me, my first gut response was like, "Oh, well, that's ridiculous. Like, the data clearly says X." And then I had to catch myself that it was such a strong response. And I don't have any financial relationship with the company, but I did create courses around it. I did review the literature, and I went out, in the profession and said, this is my opinion right now. And so I think having that, even that intellectual connection to something, I think made me feel a little bit more reactive. And I was like, oh man, this is something I really need to keep an eye on and make sure that I'm being open to other interpretations and new data, et cetera. So just sort of like checking that, I think in ourselves is important. And to your point, the longer we do something, the less we think about it, right? So if like someone comes in and we say the same spiel every time and we prescribe the same thing every time, after a while, like we just get stuck in that thinking and maybe we're less, and that's just human. But I think to use those as sort of red flags for ourselves to really double question everything.
Yeah, exactly. It's kind of like driving, where the first time you go somewhere that you don't know, you're kind of like really aware of your surroundings. And then the 50th time, you're just kind of like on autopilot, not really paying attention to anything. And you're like, oh crap, I'm driving. Hold on, let me pay attention.
Yeah. Have you read, and we should probably wrap up soon, but have you read, I think Thinking Fast, Thinking Slow? Yeah. My sister got me that book for my birthday, and I've been slowly reading through it. And I think that's part of it, right? There's sort of two ways of functioning, right? Very careful and critical, and then sort of like quick and haphazard. And both are important. It depends on the context. But I think the take home is you have to know what mode your brain is in and the fallibilities therein.
Yeah. Oh, and on our discussion sort of like of the New England Journal of Medicine that we had on our last podcast, and this kind of actually ties into it. There was an editorial that was recently published on, I think like either last week or this week. The title of it was "The Curiosity in Clinical Care" by Anup Agrawal. And it's a very short read. It's not anything that's like, super evidence-based data, data analysis or anything like that. But basically of like, don't you lose that curiosity as a clinician that you had when you were a med student, where as med students, we're oftentimes like asking, or I feel like we're asking why more often, and like really wanting to understand things, where then as like a clinician, it's almost like, hey, just get it done. We have so much to do.
Right.
And, this clinician kind of brings up some experience for a patient where she basically checked all the boxes and was like, yep, my job is done. But there were these other things that that my student was bringing up that was rounding with me in about things I didn't really think about, which made me actually want to go back and like sort of re-examine the patient and like take a little bit more time and kind of reevaluate my approach as opposed to just checking all the boxes and moving on. And just it was just a really interesting editorial piece on that I think that people should go out and read. It's only like a two-page read. I don't know. I thought it was engaging, but I think it relates a lot to what we talked about today as well.
Yeah, good point. We'll link to it in the show notes. It was a good piece. Thanks for sending it. So we'll link that as well. So thanks, everybody. I thought we were going to have more of a conversation about journalism and science and medicine, but actually, I like the way it turned, which is more about how we doctor and how we apply evidence and et cetera, and those nuances therein. So maybe another time, I would love to get a medical journalist on the show. Like, we had a philosopher of science. We should get a medical journalist. It would be fascinating to hear from their side how they approach explaining a complicated research study to a lay audience. And that's I don't
Or do they
envy that
even
job.
have the trainning in understanding how to break down? Yeah, like I don't know either. Is it just, hey, they read the abstract and then they interview one of the journal authors and then kind of go from there and create their piece, or like is
I
it
have
more
no idea.
investigative journalism, or like how does it go? I think that would be really interesting.
We should figure that out. I think there should be a credential if there isn't. And, the thing that bothers the heck out of me for that is the communication of uncertainty, right? So uncertainty is such a huge part of science and is a huge part of all these papers, but that uncertainty gets so lost in journal articles. I just see that all the time, right? And how do you communicate uncertainty? It's a hard concept to communicate to a lay audience. I get it. But anyway,
Well, I mean,
great conversation.
even in medicine, sorry, but even in medicine, there's so much uncertainty in, for as much of advancements in technology and like how advanced medicine has gotten, there's still so much unknown and so much unanswerable stuff that even as clinicians, like I think a lot of us feel uncomfortable saying we don't know. And it's a hard conversation to have with patients of like, yeah, hey, this happened. I don't know why it happened. I don't know what the outcome's going to be. There is a lot of uncertainty. And so, when we say the practice of medicine, yes, it is a practice, right? We're constantly practicing medicine. As much as that kind of term is thrown around, whether it's derogatory or not, the ultimate reality is there's so much that we don't know, and we are all just trying our best with what we have.
I think that's true. It's such a good point. And I don't know about you, but it was really hard for me when I started off to say things like, I don't know, to a patient, right? Because I felt like I was supposed to be the expert. And the longer I practice, the more comfortable I am. And just yesterday, a patient it was their spouse actually, was on the call and had a really great question. I just got so excited. I was like, I have no idea. What a great question. And I just was thinking back, I was so excited about not knowing. And I was thinking back to be like, when I first got out of school, like I would never say something like that. I would be embarrassed that I didn't know,
Which makes sense because like you spent all this time, all this money, you've devoted, hours and hours and hours to studying. You graduate, you're fresh out of school, and the first thing that you say is, I don't know.
Right. That's right.
Like, what did you go to medical school for?
Yeah. To know where to look it up. Yeah, I don't know, but I know where to look, right? That's
right.
That's why we go to medical school. All right, man. That was awesome conversation. Thank you. And let's see if we can't wrangle. If any of your listeners know anything about medical or science journalism, we would love to get more information and maybe a contact, because I think we should have a science journalist on the show.
Yeah. All right, Josh, where can people reach us?
They can reach us on all the socials. And check out the actual website. So this is the podcast of the flagship website, which is drjournalclub.com, drjournalclub.com. We've got different membership levels, stay up to date with recent evidence and research, then also skills about how to critically evaluate evidence, etc. We also have a class, what we call EBM Bootcamp, which I think is really relevant to our listeners. So I'll put a link for that in the show notes as well. But yeah, check us out on social, interact with us, send us emails, josh@drjournalclub.com, josh@drjournalclub.com. And we'd love to, you send us a recording. We'd love to play your question on the show. Send us a paper. Like, when SSL was like, I'm curious about this paper and I don't know what to think. What do you guys think? Right. We're happy to do that as well. So you just reach out to us and let's get this community going.
Yeah. For social, it's Twitter and Instagram, both at Dr. Journal Club, DR Journal Club. And then for the website, we do put stuff on there that we don't talk about on the podcast. So there's some journal articles that we do talk about and kind of break down in detail and with graphics and everything. So if you want more of a visual as opposed to just audio, it's on the website as well.
Sounds good. All right, take care, everybody. We'll talk to you next week. If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media. At Dr. Journal Club, Dr. Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.